Hello, this is a Camtasia presentation on the digestive system. So this is week 7 of the semester, and in chapter 23 of your textbook there are some references and there's some material that you'll have to look up, and you'll be responsible for that material. Again, this is my favorite internet artist. So here is the stomach, and this is the pyloric sphincter or valve, which is the link between the stomach and the upper part of the small intestine. This is the upper part of the small intestine, the duodenum, and here's the pancreas, and even with the pancreatic duct that empties enzymes and sodium bicarbonate into the duodenum. So just excellent work. And this I found a couple years ago, and this is a lady that knits body parts, organs. So this is a knitted version, for all you knitters out there, a knitted version of the digestive tract, including small intestines, large intestines. Look, there's even a little green gallbladder there. So that's what I'll be doing in my old age. So the functions of the digestive system are relatively simple. Essentially, the digestive system is responsible for taking in food, breaking that food down into smaller molecules that our cells can use, absorbing those molecules into our bloodstream so that our cells can have access to them, and then getting rid of waste products, so any stuff that our cells don't use, how do we get rid of that? So one of the main functions of the digestive system is to break down food that we eat into smaller bits so that can be used by cells. And our digestive system can do that in two different ways. First of all, just simply mechanically, so just by physically crushing large bits of food into smaller bits of food. So for a good example of that is chewing, although this happens in other places in the digestive tract too, as you'll see, but chewing is a good example. Our teeth and tongue and mouth mush large chunks of hamburger or whatever it is into smaller bits. However, even mushing things into smaller bits is not going to be small enough for cells to use, and so our digestive tract also chemically digests food. So this is where we take small bits of food and we break them down further by a series of chemical reactions. And a really key word, so I'd like you to circle this, is enzymes, and that is in order for these chemical reactions to occur, they require an enzyme. And so an enzyme is a substance that is a protein, it's a molecule, and where another molecule can bind onto it, and then it allows that to be split apart. And so we end up with smaller products in the end. Enzymes, just by the way, can also work in the other direction. So they can take small bits and then bind them together to make bigger bits. But the enzymes we're going to be talking about with regard to the digestive tract are ones that break things down into smaller bits. We talked about this when we did nutrition. So how small must food be in order for these molecules to be absorbed into the bloodstream and that cells can then use them? So when we talk about food, we're going to talk about our three major macronutrients: carbohydrates, fats or lipids, and proteins. And if you remember back to our nutrition module way back in the fall, carbohydrates had to be broken down into simple sugars. So simple sugar, so like glucose, for example, is a simple sugar, and that's small enough for our digestive tract to be able to absorb it. The enzyme that breaks carbohydrates down, the group of them are called amylases, A-M-Y-L-A-S-E-S. Lipids or fats have to be broken down into monoglycerides and free fatty acids, and the enzymes that break them down are called lipases, L-I-P-A-S-E-S, and proteins have to be broken down into individual amino acids, those building blocks of proteins, and the enzymes that break down proteins are called proteases, So this is our entire digestive tract from start to finish. So we take food in through our mouth, our oral cavity. Our teeth and tongue play a role. Our palate plays a role in making things mechanically smaller. Salivary glands play a role in producing saliva. And then that food then goes, when we swallow, goes down through the pharynx or throat, and then into the tube that runs behind the trachea, and that's called the esophagus. Down the esophagus into the stomach, and then from the stomach it empties into the upper part of the small intestine, which is called the duodenum. Along this way, the liver and gallbladder play a role, as does the pancreas. And then food moves into the rest of the small intestine, which is all this middle, smaller diameter stuff. And there's a couple of parts to the lower part of the small intestine, the ileum and the jejunum. And then into the large intestine or colon, and then finally into the rectum, the anus, and then the waste products then see the outside world. Okay, star here. So in order for all of this food that we eat to move through that entire digestive tract from start to finish, we have to have some mechanism to push that food along. And that mechanism is called peristalsis. And what peristalsis is it's waves of contraction and then relaxation of the smooth muscle that surrounds all of these hollow organs. So if you think of our esophagus, for example, our stomach, even our pharynx, stomach, small intestine, large intestine, there are all these hollow organs, and in the walls surrounding those hollow organs is layers of smooth muscle. And the smooth muscle runs in different directions. So there's one layer that runs lengthwise and another layer that runs in a circular direction, and the stomach actually has a third layer running kind of crossways like this. So there are these layers of smooth muscle, and when the smooth muscle contracts, right, it squeezes it makes the diameter smaller, it constricts. And when it constricts, that allows the food then to be pushed along the tract, kind of like squeezing a tube of toothpaste. If you want to get the toothpaste out, and I'd like you to kind of visualize this, if you squeeze it, then the toothpaste moves down. And then if you want to get it more out again, then you squeeze it further down the tube, and then it squishes along, kind of like what you see here. So here's a contraction of smooth muscle. And then the next smooth muscle contracts, it pushes it further down. The next bit of smooth muscle contracts, pushes it further down again. So here, this is actually an image taken with a technique called a barium swallow, where somebody swallows a substance that allows it to fluoresce so we can actually see the digestive tract. So it's often used for diagnosing certain conditions. And in this case, you can actually see mid-peristalsis. So this is the esophagus. The stomach is down here. And we can actually see the section of the esophagus where the smooth muscle is contracting, and it's pushing all of this stuff down. I actually have a video of peristalsis that I will post for you so that you can see. It's a barium swallow, and I'll post that for you. Okay, I'd like to start at the very top of the digestive tract and work my way down, and then all along the way we'll talk about the anatomy and the function, but we'll also maybe talk about some disorders that again are relevant to your field. So the mouth is the opening for entering, for food to get into our digestive tract. And of course there is mechanical digestion that happens in the mouth, and this is teeth and tongue. The palate, which is the roof of the mouth, also plays a role in this, and it mixes food with saliva. We'll talk about that in a couple minutes, and mashes it and breaks the teeth down. We have 32 permanent teeth that start growing in at about the age of 6. When we are little kids, we have 20 what we call deciduous teeth. Deciduous meaning just like leaves, they fall out. We have incisors at the top and the bottom that are designed to cut through food. We have canines We have 4 canines, top and including 2 on the top, 2 on the bottom, and these are designed to tear at food. So lots of meat eaters have big canine teeth. And then we have molars, premolars and first, second molars that are designed to grind food, so they break food down in that way. There is a third set of molars that we call wisdom teeth, and the wisdom teeth develop usually in about late teens or early 20s. And if there's enough space in the mouth, they just grow in normally. However, if there's not enough space, they may come in on an angle, and we say that they're impacted in the, and so they becomes kind of stuck in the jawbone, and then they have to be removed surgically because they put pressure on the surrounding teeth, and it can be quite painful, and they can develop an infection. So some people, their wisdom teeth come in and they have just an extra set of molars, and other people have to have them removed sometime in their early 20s. This is a cross-section of a tooth showing the different layers of the tooth. The inside part of the tooth is called the pulp, and that's the part of the tooth that contains all of the nerves, the blood supply to the living cells that are in the tooth. The next layer is called the dentin, and this is a layer of calcified tissues, so they contain a lot of calcium, so they're a little harder. The hardest layer of the tooth is the outer layer here called the enamel. And the enamel is actually formed during tooth development when way back when you were an infant, and it cannot regenerate. And so that's why we're always so careful about the enamel of our teeth. That's why your mom said, "Don't chew on that metal thing," or whatever it was. And that's why we, brush our teeth and use fluoride, which are all things that help keep our enamel intact. If the enamel breaks down, then of course this more sensitive dentin and softer tissue is exposed, and things can break through that. And then of course then we end up getting to the nerves and the inside, the pulp of the tooth, and that can be really painful. The part of the tooth that we see is called the crown. The part that is level with the gum or the gingiva, which is the fancy way of saying gum, that is called the neck. And the part that is embedded in the jawbone is called the root of the tooth. And there are 2 little canals that go down from the pulp, which join up with the blood supply and nerves that are, running through the jawbone, and that's what connects the tooth. Of course, one of the biggest issues with teeth is cavities or caries. Dental caries is the fancy way of saying that, which is caused by a tooth decay. Now, what causes cavities is actually bacteria. Now, we have bacteria that live in our mouth, and everybody does, and there's not a lot we can do about that. The bacteria love to feed on things that are in our mouth, in particular sugar. So anything that is a simple sugar attracts the bacteria, so we'll have more bacteria in our mouth when we eat sugary things. The bacteria live on the teeth, and then they secrete this very sticky substance called plaque. So in this picture here you see on the right, this green, these are the bacteria, and this brown stuff, this is all the plaque that is being secreted by the bacteria. The plaque is very sticky, so more bacteria gets entrapped in there, and they get more plaque and so on. Now the thing that happens is that the bacteria, as a byproduct of their feeding on things, they produce a very weak acid. And the acid is what can harm the enamel. And you can actually see the white of the tooth just underneath here. And so if the enamel dissolves, then it forms a little pit. And then we can see that on the left side over here. So there's a little pit in the enamel. And we call that a cavity or a caries. The danger is, of course, that once the enamel has been breached, that now this weak acid and infect other bacteria and things can get inside the tooth, and it can cause an infection, or it can cause decay of the entire tooth from the inside out. One of the things that inhibits the growth of bacteria is our saliva, because it is also acidic, and so it will prevent bacteria from growing, and it kind of cleans our teeth. And so that's why dentists always recommend, if you can't brush your teeth, eat something, because it causes saliva to be released, and then that helps clean your teeth. When we sleep, we don't produce as much saliva as during the day, and so that's one of the things that happens to us when overnight. We wake up in the morning, we will have more bacteria in our mouth. It also happens that the stuff that this bacteria releases is kind of smelly. And so this is what happens to cause morning breath, is that we have less saliva during our sleep, the bacteria accumulate, and then we have kind of stinky breath. And it's always good to brush your teeth first thing in the morning. The fancy way of saying gum is gingiva, and so inflammation is itis, and so inflammation of the gums is called gingivitis. And it's caused by plaque, again, which is the stuff that's secreted by the bacteria, below the gum line, and it hardens into something we call tartar. So tartar is just hardened plaque, and it's so hard that it has to be actually scraped off with those little curly metal instruments that the dentists use and dental hygienists use. Now this hard stuff, and you can kind of see actually in this particular picture, you can actually see the tartar at the gum line, irritates the gums because it's this hard bumpy stuff, and the gums are very soft, and the gingiva become inflamed. Of course, anything that's going to attract bacteria, like diets high in sugar or not brushing your teeth enough, those types of things, immunodeficiency, if your immune system is not getting rid of bacteria sufficiently, or certain types of saliva, and that depends on genetics, then that will increase your risk of gingivitis. So the very first signs of gingivitis are red gums, like you see in this picture, bleeding, particularly when you brush your teeth, that it'll cause bleeding of the gums, but eventually it can actually cause the teeth to lose their attachment to the jawbone and fall out. Just a note is that persons with Down syndrome are at a greater risk for gingivitis than the general population. So treatments for gingivitis and tooth decay, obviously I think we've been hearing this since we were in kindergarten or before, but brushing our teeth, right, removes the plaque and controls the growth of bacteria. Flossing, because it removes any food or plaque that happens to be between the teeth or down at the gum line. And fluoride, because fluoride hardens the enamel. And so we get fluoride in small amounts in our drinking water in Ottawa, and also, of course, in toothpaste. And there's been some controversy about fluoride, but all of the evidence that I have looked at suggests that fluoride is definitely plays a huge role in keeping dental caries down in our population. Okay, the roof of our mouth is called the palate, and it separates our mouth from our nasal cavity. So if you look at this picture here, this is the palate right here. The palate is actually made up of two parts. There's a hard palate, which is made up of bone, and that's at the front, and then a soft palate, which is at the back, and that's made up of muscle. One condition that is more common in people with disabilities, particularly genetic syndromes, is called cleft palate. And this is present at birth, it's congenital, and it's an opening in either the hard or the soft palate or in both. And of course this is a problem because then you have an opening between your mouth and your nasal cavity, so that when you eat and swallow, food and liquid can go up into the nasal cavity, and of course then it can be inhaled or aspirated, and can be very difficult to eat. So there is a hereditary component to this, so it can run in families. It's also hooked or associated with different types of genetic syndromes. It can also be caused by any problem that occurred during pregnancy at the time that the palate and the mouth was developing. Interestingly, it's more common in males, and as I said, it can be associated with some specific genetic syndromes. So here's a photo of a cleft palate. It's what you see on the left. So you can see that opening in the roof of the mouth that would go right up into the nasal cavity. And this is the same child after surgery. And again, the big issue is eating and swallowing. And because when things go up into the nasal cavity, as you may know, if you get something up your nose, you're more likely to inhale it. And then that increases your risk of infections in the bronchi, bronchioles, and in the alveoli. Also, because things can go up the eustachian tube from the throat, it increases your risk of middle ear infections too. What they usually do is they try to do surgery as soon after birth as possible, if they're able to do that, because even as an infant, it's going to be difficult to eat. Sometimes several surgeries are needed. Often, that when the palate is developing, the upper lip is also developing. So if somebody has cleft palate, they may also have a split in the lip, which is called cleft lip. And so they may require a couple surgeries to close both of those up, and they may have to learn how to use the roof of their mouth to speak, so that may require some speech therapy too. Our salivary glands are a set of glands, and here's a picture that shows their location all around the mouth, and they've got ducts that empty into the oral cavity, and these glands produce saliva, which is a combination of mucus plus a fluid. Now, saliva plays a pretty important function in our digestive tract. So first of all, we can't swallow without saliva. So it makes food liquidy, and it binds the food together in what we call a bolus that allows us to swallow it. We can't swallow it if it's all in little tiny pieces. Saliva also contains antibodies, which inhibits the growth of bacteria, so that helps keep our teeth clean, as we talked about before. It dissolves substances, so that's how our taste buds work, is that when there are chemicals that are dissolved in saliva, we can taste. And the final thing is that it contains an enzyme, an amylase, so it's going to break down carbohydrates, and specifically the enzyme that's in saliva breaks down starch. So it's the very first place in our digestive tract where chemical digestion starts to take place. Okay, so this was a turning point question. So when is saliva released? When food enters the mouth, when any object enters the mouth, with the sight, smell, or thought of food, with emotional stimuli, or is it released continuously, or all of the above? And the answer is all of the above. So even if we are thinking about food, if we smell or see food, sometimes with emotional stimuli, for example, if you think of your grandmother, you might reduce saliva because she bakes fresh bread. And if anything enters the mouth, so if you hold your pencil in your mouth or your flashlight in your mouth, then you get a little thing of drool that kind of comes down the side because it stimulates the release of saliva. Little dating fun fact. I don't know if this is dating appropriate, but we produce about 2 to 6 cups of saliva a day. Okay, our esophagus. So this is our food tube. It runs behind, towards our back, behind the trachea. So we did the respiratory system already, and when we breathe air in, that goes down our trachea and then into our lungs. Our esophagus goes from our mouth and pharynx, but then it goes behind the trachea and then down into the stomach. So it's a passageway for food. It's very muscular, and we can actually see, this is an endoscopic picture, so they have a little camera that a person can swallow, and then they can visualize the inside of the digestive tract. So we're going to be looking at a number of these endoscopic pictures throughout our journey today. So you can actually see all this smooth muscle all along the walls of the esophagus, and of course that's so that peristalsis can occur, so that food can move down. Just by the way, think about it. Can you swallow something if you were standing on your head? Will food still go down your digestive tract if you are standing on your head? I hope you said yes, because of course that's all about peristalsis. Star. So swallowing is a very important aspect for DSWs, and that's because a number of individuals in the field may have and will have swallowing issues or swallowing problems. So swallowing is actually not a very simple process. It's a complex process, and it involves using our tongue, our soft palate, our throat or pharynx, and the esophagus. Now, swallowing begins as a voluntary action. So if I said to you right now, swallow, I'd like you to try. There, I just did. Yeah, I can do that. I can say I can swallow whenever I want to. But that's only the beginning. So once you start the swallowing reflex and the food passes or saliva passes over the back of the tongue, then that stimulates receptors in the wall of the throat, and from then on it becomes totally involuntary. So if I asked you to start to swallow, and if you try to stop a swallow partway through, you can't do it because it's a reflex arc that involves all of the nerves, and those information goes through those nerves without our being able to voluntarily control that. There are 3 main phases to swallowing. I'm not sure if you did this already in preps, but there are 3 phases to swallowing. The first phase is called the oral phase, and that's where your tongue pushes food to the back of your mouth. And this is important because you can't swallow if your tongue doesn't do this. So right now, just try for a second. Stick your tongue out and then try to swallow. You'll find it's quite difficult. The second phase is called the pharyngeal phase, and this is where the soft palate, which, remember, that's the back part of the roof of our mouth, it seals the nose from the throat. So again, that when we swallow, food doesn't go back up into our nasal cavity. And then our larynx rises and the epiglottis covers the trachea, and we talked about that already with the respiratory system. So if you actually put your fingers on your trachea over your larynx, that's where your Adam's apple is, and you swallow, you can feel your larynx going up, and at the same time that little flap of skin is covering over the top of the trachea so that food doesn't end up going down into our lungs. And then the muscles surrounding the pharynx or throat contract, and that pushes food down into the esophagus. And then, of course, the esophagus takes over, peristalsis and all of these rhythmic contractions of the smooth muscle down the esophagus, and that pushes the food then down into the stomach. So problems with swallowing is called dysphagia. And as I said earlier, dysphagia is much more common in the field of developmental services and people with developmental disabilities than in the general population. And it's because swallowing requires, a combination of muscular control and nervous system and so on. So some common causes of dysphagia could have to do with the swallowing muscles themselves, so the pharynx and the tongue, and if those swallowing muscles are weak. It could be a problem with the nervous system, so that could be brain or any of the peripheral nerves that run to and from those muscles that control and coordinate swallowing. It could be a structural problem, such as the cleft palate or lip, or even things like poorly fitting dentures could cause problems swallowing. It could be some sort of damage or disease to the esophagus, so GERD or acid reflux, or a narrowing of the esophagus or tumor. It could be side effects of drugs, so for example, corticosteroids, NSAIDs like ibuprofen, those are drugs that can cause problems swallowing. Lots of drugs cause dry mouth, a lack of saliva. So any of those things could cause a problem swallowing. I'd like you to think for a minute. Usually when we're in class, I ask you to get into an educational clump and kind of think about what are some signs and symptoms of dysphagia. So what are some things that you would normally see if somebody was having difficulty swallowing? I'll give you a few, but I'd like you to come up with some yourself too. And you may have experienced this already working in the field. But certainly if somebody has, it looks like they're in distress when they're trying to swallow. So they have pain, or they look like they're having pain, or they're having difficulty starting the swallow, or if there's excessive mouth movements during chewing and swallowing, like they're really struggling to get the food down. Of course, anything like coughing or choking or gagging or any of those things. A person that gets a sensation of food being stuck in their throat or chest. A person that requires several swallows to get the food to go down, or if after they swallow there is food still in the mouth, we call that pocketing. Excessive drooling, regurgitation, so they swallow and food comes back up, gurgling sounds, even somebody that has frequent bouts of pneumonia, you might suspect that perhaps they are actually inhaling some food or fluid, and so that the cause of those frequent bouts of pneumonia might be dysphagia. There's a lot of behavioral things that you can look for, things like refusing to eat, or increased behavioral problems around food, around dinner time, or taking a really long time to eat, or loss of appetite, or loss of weight, or people wanting to be all by themselves because they're embarrassed because they're having difficulty swallowing, especially seniors. So those are a few things, and I bet you can think of a bunch more. The reason that dysphagia is so important is that there are a number of health risks. Primarily, if a person can't swallow fluids, they can become dehydrated. If they're not getting enough nutrients, they can become malnourished. And the last thing is that dysphagia can really lead to pneumonia. And this is caused when they inhale or aspirate food or fluid, and then the lungs then develop an infection, and that can be life-threatening. There are also some other things, like when a person is having difficulty swallowing, then they may develop an aversion to eating, an aversion to food. And the last are things like embarrassment and isolation. So for example, seniors, very often, if they develop dysphagia, they may be embarrassed to drool or to have to swallow or spit food back out, and so as a result they eat by themselves. And food in our society is a very social event, and so this can be very isolating for a person until it is diagnosed and treated. Usually when they diagnose dysphagia, it's a speech-language pathologist that evaluates the swallowing, and they look at everything from their medical history to muscle coordination, their posture, behavior. They may order other tests like an endoscopy, where they take a little camera and look down to see if there's any structural defects, or an x-ray with that barium swallow that I showed you. I know you looked at a lot of interventions when you did preps, so ultimately if you can correct the underlying cause, so for example stop the drugs that are causing dysphagia, or surgery to correct cleft palate, then that's great. Otherwise, there's a whole whack of exercises that somebody can do to strengthen and increase the sensation and coordination of the swallowing muscles. And then, of course, you looked at, with Carl, all sorts of special foods, different textures, thickening agents, different types of equipment and techniques, like, for example, changes in a person's posture to help with swallowing, and then drugs, things that will decrease acid secretion, those types of things as well. Okay, we're going to stop here. So this is the end of part 1, and so look for part 2. Thanks.